Okay, so a very good evening to one and all present here. I, Dr. Komal Lalwani, welcome you all to today's community of practice session on improving quality of pediatric gastrohepatology and liver transplant services in India. Let's make it available to all by Dr. Aarti Pavaria. Now, I request Professor Vikram Datta to introduce our speaker for the day to our esteemed audience. Professor Vikram Datta is the Director Professor at Department of Neonatology, Lady Hardinge Medical College, New Delhi. He is presently a President of Nationwide Quality of Care Network and Vice President of National Neonatology Forum, India. He is a guest editor at BMJ Open Quality South Asia edition. He is a member of editorial board at International Journal for Quality in Healthcare Communications. He is expert at the International Society of Quality in Healthcare and lead at National Mentoring Group and Technical Resource Group. He is also a lead at Sustainable Model for Lakshya by Ministry of Health and Family Welfare, India. He is a member of Quality, Equity and Dignity Working Group by Ministry of Health and Family Welfare, India. Over to you, sir.
Thank you so much, Dr. Komal. Good evening, friends. It is a warm privilege to welcome colleagues from the gastroenterology and the hepatology division of the country and very eminent panelists and chairpersons today for this Communities of Practice platform. I have the pleasure of inviting Dr. Aarti. So can I have the introductory slide for Dr. Aarti? Dr. Aarti Pavaria is a well-known face for NQC and colleagues, and it is her eminence that has led her to achieve great heights in her career. She's a young consultant, but she has achieved great heights, a very compassionate person, I should say, and a person for whom quality comes naturally. Dr. Aarti, a formal introduction to her, she is a senior consultant and clinical lead pediatric gastroenterology, hepatology and liver transplant at Global Hospital, Mumbai. She has the distinction of being the first female pediatric hepatologist of the country with formal training in both pediatric hepatology and gastroenterology. She has a rich experience in pre and post liver transplant care in children and management of various hepatobiliary and gastrointestinal diseases in children. She's been a recipient of many recognitions and awards, which include Joint Asia Pacific and American Research Workshop Award, Young Investigator Award at the Asia Pacific Association, Young Investigator Award 2017 at the American Association for the Study of Liver, and Investigator Award by the Indian Society for Clinical Nutrition Conference in 2016. Dr. Aarti has published various articles in national and international journals. I have the pleasure of handing over the stage to Dr. Aarti. But before that, I have the pleasure and the privilege of introducing our two very eminent chairpersons for this session. As friends, as you would know, that this is a dedicated session on pediatric and neonatal hepatobiliary and transplant related issues and quality of care. I have the pleasure of inviting Dr. Vinendra Pamecha, who's Professor and Head Department of Hepatobiliary Surgery and Liver Transplantation at Institute of Liver and Biliary Sciences, New Delhi. I'm sure everybody has heard about ILBS and the quality of care and the patient satisfaction, which is synonymous with the name of ILBS. And we are very privileged to welcome Dr. Pamecha here. Dr. Pamecha has more than 20 years of clinical academic teaching experience, and he has established a liver transplant program for both adults and children at ILBS, with results at par with the best international centers, a first for the public sector hospitals in India. So I think we would be very eager to hear about the inputs from Dr. Pamecha and how quality of care, and about a little bit about sir's journey as well. He was instrumental in starting the MCI recognized super specialty MCH training program in hepatopancreatic biliary surgery, a first in the country, and was awarded the fellowships in multi-organ retrieval, liver transplantations, and hepatopancreatico-biliary surgery by the European Board of Surgery in 2009. He has received the prestigious FRCS in hepatopancreatico-biliary surgery in 2010, and his clinical and basic science research has been published extensively in leading journals of the specialty. So welcome, Dr. Pamecha. I have the pleasure of introducing a close colleague and friend of NQCN and eminent member of the CAHO. Dr. Sanjeev Singh needs no introduction to the NQCN communities of practice. Dr. Sanjeev Singh is the Medical Director at Amrita Institute of Medical Sciences and Research Center and the Chief Medical Superintendent at Amrita Institute of Medical Sciences, Kochi. He is a co-chair of the Research Committee at NABH and the lead assessor for International Society for Quality, that is ISQA, chairman of the Technical Committee of AHPI and Health Sector Skills Council of India, Government of India, improvement advisor, trained as an improvement advisor at the Institute of Healthcare Improvement, US, an ambassador from India to Society of Healthcare Epidemiology of America, and has been adjudged as the hero of infection control by EPIC, US. And he's also the member of Drug Safety Council to Government of India and on the National Advisory Body of the Occupational Exposures and Healthcare Without Harm. So I think we have a very eminent panel today, and we would also be very, very eager to hear about the experiences and some inputs about patient safety and quality, and especially with a special reference to hepatobiliary pancreatic disorders and gastrointestinal disorders. So I think with that illustrious panel and speakers on board, the quorum is complete for today. And over to you, Dr. Aarti, for an engrossing session. And the floor is all yours, ma'am.
Thank you very much, sir, for giving me the honor to speak on a platform like this and for creating NQCN where young people like me can actually feel that our thought process of improving the quality in our specialty can actually become a reality by looking at how the neonatology has come up in such a good way with improved quality. I also would like to thank Dr. Sanjeev sir and Dr. Pamicha sir for agreeing to chair the session at such a short notice. And I would try to be brief and also touch upon points which I feel can make a difference to the ever-improving practice of pediatric gastroenterology, hepatology, and liver transplants in the country at present, especially for children. So at the outset, I would like to start my talk by saying that if I look at the worldwide prevalence of cirrhosis in children who are under 18 years of age, there are about 10 million children who suffer from liver cirrhosis because of numerous changes. Even though there is no national data for the country, but extrapolating it from what we have, in India, out of 1.3 billion population, 472 million children are less than 18 years of age. That means around 25 million children are born every year in India, and India accounts for 1/5 of the world's annual childbirth. 18% of the world's under 18 age group children reside in India. By extrapolating this data from the world data, it is estimated that around 1.6 million children under the age of 18 years suffer from liver cirrhosis of various causes in the country. But we have very many challenges. India in the last decade has emerged as a good destination for medical tourism, and we are apprised worldwide for our advanced and affordable medical services. However, there remains a challenge, and I do give it a thought many times, that have we been able to make the same healthcare affordable and accessible to the children of this country? And this is what provokes me at times, of how it's just not about one single child who reaches to you in a tertiary care setup that we change the life and we attempt to change the life or save a life, but it should be given to even those children who are not able to reach or not able to afford a private healthcare. The foundation of pediatric hepatology and gastroenterology has to be strong to make it available to all the children, and then do the best of the liver transplant services and save innumerable lives which otherwise would have been lost had liver transplant not got established in the country. So from there, I understand that in India from the world, India is the second largest transplanting country in the world. When we take together the kidney, lung, liver, and heart transplant, of late, small bowel and pancreatic transplants have also been increasing, and India stands second in the world. at present, we are able to do the best quality of liver transplant and give the best results using our indigenous skills and infrastructure. The age and weight of the child is no more a barrier as it used to be thought many years back. We have excellent post-transplant outcomes, even with very small babies weighing 4 to 6 kgs as well. So the way transplant services in India has improved.
Dr. Aarti, would you be, sorry to disturb you, would you be sharing your slide, or it will be like this? Because we are not able to see your slides.
Sir, I am sharing my slides.
Okay, but unfortunately, I think it's not visible to us. Can you just share them again, ma'am?
Yes, sir.
Dr. Komal, can you just help Dr. Aarti? So sorry to disturb you.
I'm sorry, I thought now,
I'm so sorry. You can put it in screen show mode. Yeah.
Is it visible now?
Yeah, it's visible. You can put it in slideshow mode now. Yeah, that's fine. Thank you so much.
So here from the challenges when we go, and being the second largest transplanting country in the world, we have a milestone where we did the first pediatric liver transplant in the year 1998. And from there on, the journey has been phenomenal. We have been able to do all kinds of difficult Dominos, ABO incompatible, and all kinds of transplants in the country at present, and successfully doing it at many centers. So in the last 22 years, we have 135 licensed liver transplant centers in India. If we look at the data of pediatric transplants, in the initial 9 years, that is from 1998 to 2007, only 318 transplants were done. And it is important to realize at that time, 70% of the population who was receiving the liver transplant were foreigners. The scenario has changed now completely. Between the year 2015 to 2021, there are approximately 1,500 pediatric liver transplants, and 70% of the population are Indian children who receive it. So now, the same liver transplant, which was not much available to the children 10 years, 15 years back, is now being made available and affordable. From this platform, since we have a lot of diseases, but I would like to put emphasis on 3 diseases here. That is hepatitis A infection, biliary atresia, and Wilson's. The reason I chose them is because hepatitis A is unfortunately still the most common cause of acute liver failure in children in India. And we lose every year thousands of children because of a vaccine preventable disease. And that is what has made me choose this infection for today. The second is biliary atresia, which is the most common congenital liver disorder. And the third is Wilson's, which is the most common genetic liver disease, and which affects thousands of children in the country. Now, if we look at even the indicators for pediatric liver transplant, what were the different indications? We realized that biliary atresia accounts for around 60% of all the pediatric liver transplant in India and world across, followed closely by metabolic liver disease, from which Wilson's is the most common, and acute liver failure, for which India has hepatitis A as the most common indication. Even if we look at the total data, from 200 pediatric liver transplant from one of the leading pediatric liver transplant centers in the country, 36% of them were biliary atresia, 29% of them were acute liver failure, predominantly hepatitis A, and 12% were Wilson's disease. So now, as I've said, that hepatitis A actually ranks 6th among the infectious vaccine preventable causes of worldwide mortality. It is ahead of mortality caused by pertussis, tetanus, varicella, and diphtheria at present time. India has been witnessing an epidemiological shift in hepatitis A, especially from the year 2011 to 2013. We were in the high endemic zone. Now we are in the intermediate endemic zone. What it implies is that previously, younger children less than 5 years were getting infected more often, and being younger, they were having less severe infections. But the more recent data in the last 7 years has been showing that even at the age of 10 years, only 60% of children are seropositive for anti-HIV antibody. That means we still have 40% of the population of children who are susceptible to hepatitis A. Also, being advanced in age, this is more likely to be causing more severe disease, and we will have more number of children who are otherwise healthy getting hepatitis A infection and leading into acute liver failure. The virus hepatitis surveillance in India from 2011 to 13 also showed the same thing, that in 2013, there were more children between 1 to 13 years of age who were getting hepatitis A infection, which was laboratory confirmed, as against 2013, where that peak started to rise after the age of around 10 years and young adulthood. And we know that hepatitis A is responsible for 70 to 80% of all acute viral hepatitis in the country, and also 40 to 60% of all acute liver failure, as compared to only 1% in the West. So we are still losing children to a vaccine preventable disease. This is one of the data wherein, this is from the Institute of Liver and Biliary Sciences, wherein out of this has been covered over 7 years. Out of 1,000 children who came with acute icteric illness, around 1,000, there were 431 who were hepatitis A positive. And it is important to note that 50% of them presenting to a dedicated liver ICU, a dedicated liver hospital, received needed ICU admissions. And even with the best of medical management, 41% of them had poor outcome, in terms that 31% died and 10% required liver transplant. Now, with this kind of a statistic in an institute like ILBS, we can understand what might be the scenario in other areas which do not have those dedicated liver ICUs. And hence we realize that from all the viral hepatitis, the mortality is quite high. The mortality ranges from 35 to 44% for acute liver failure by viral infection, as compared to the US group, which is the PAL study group, where only 0.9% of all the liver failures are because of viral hepatitis. Now, if you look at what we can do, we can see what Argentina has done. For them also, acute liver hepatitis A was the most common cause of liver failure. But in 2005, they started a single-dose vaccination, and they completed the single-dose vaccination for the population, and they found that all 100% of the vaccinated individuals were seroconverted. They also had the expectation that in case an infection occurs after the natural immunity wanes off, it will act as a natural booster, and hence they gave only one dose. And high titers of the seropositive anti-HIV IgG antibodies were present in 97% of the population after 9 years. What difference did this single dose of vaccination made? This is very remarkable that after 2006 to 7, the cases of acute liver failure because of hepatitis A literally became nil. Their children who either died or were transplanted because of hepatitis A literally became nil. And that is why when we look at even the WHO position paper on hepatitis A, it recommends that the country who are undergoing transition from a high to intermediate hepatitis A endemicity should consider introduction of large-scale hepatitis A vaccination. And it also is recommending the Argentina's one-dose strategy in case to make it more cost-effective for a developing country. What I feel is that even though since many years there had been multiple chances where people have spoken about the need of hepatitis A vaccination, and the government has yet to decide on whether to make it universal or not. But at least a point where we can emphasize is that if we put this hepatitis A vaccination onto the mother and child protection card, more parents would be able to take it. On a personal note, in case what I have seen in practice also is that no parent, if we tell them the severity of hepatitis A, what hepatitis A infection can do, they will not refuse to give that vaccine, which is costing somewhere around 1,200 to 1,300. The only problem is that they don't know that it has to be taken. Everybody knows about hepatitis B and C, but for children and the parents, they are not much aware of hepatitis A. So this is one point where we can create awareness about hepatitis A and get more children vaccinated, either from the government as pilot project or from by creating awareness, and the parents can take vaccine on their own. The second disease that I would like to move is biliary atresia. It is the most common congenital liver disease. The incidence in India is 1:8,000 to 1:12,000 live birth. As per the WHO definition, any disease which is less than 1:1,000 live birth qualifies as a rare disease. So in that context, biliary atresia does qualify as a rare disease. It is the most common indication for liver transplantation, accounting for at least 60% of all the transplants. And the prognosis of an untreated biliary atresia is extremely poor. The survival with native liver, if the biliary atresia is untreated, is roughly 2 to 2.5 years. One important thing to realize is that how do we pick these children of biliary atresia earlier to change their outcome? There comes what we call as the neonatal cholestasis definition. All the undergraduates, all the pediatricians are aware of this. Only the important issue is what we also felt while I was practicing is that the importance of looking at the stool color and looking at the urine color was lacking even at the centers where, even at many of the medical colleges, or even when we receive referrals from across the states. This is an important thing which we should now emphasize, that every time neonatal jaundice, neonatal cholestasis is there, it is mandatory and it is very important to look at the stool color, document the stool color and the urine color. By definition, we know that conjugated or direct hyperbilirubinemia is any bilirubin direct bilirubin which is more than 1 milligram if the total bilirubin is less than 5, or if the total bilirubin is more than 5, then more than 20% of it is direct, it is called neonatal cholestasis. In short, whenever we find a child whose direct bilirubin is more than 1, that child needs pathological evaluation. It would be 60 to 70% of the chances that the child would be biliary atresia. Rest 30%, they would be something else. But this child needs to be on follow-up and hence cannot be left without a follow-up. This is a very important thing to be noted even in the nurseries, that whenever we do a liver bilirubin, it is important to include both the fractionated bilirubin as well. Now, if we look at the changing spectrum of neonatal cholestasis over the years, this change of spectrum is essentially because we are now knowing more and more diseases apart from biliary atresia, others like progressive familial intrahepatic cholestasis, Alagille's disease, and other kinds of neonatal cholestasis, and hence the one big chunk of almost 52%, which we used to call idiopathic neonatal hepatitis in the era from 1970s to 2000, is now being replaced by clear-cut other diseases which cause neonatal hepatitis. So this change has actually brought in, we can now diagnose, prognosticate, and even prevent another child of the same disease to be born in the family, especially when the diseases are progressive familial intrahepatic cholestasis, Alagille's, and bile acid synthetic defects, because we know their genetic, we can do the genetic workup, we can do a prenatal genetic workup and prevent other children for the same disease to be born. Now, if I look at the more detailed, the neonatal cholestasis spectrum, still biliary atresia and choledochal cyst, and in that biliary atresia actually is the most common cause. There are so many other causes, but biliary atresia is something which we cannot run away at any time. Also important to realize is that the idiopathic neonatal hepatitis, which was being labeled to many of those children who would later come to us at 3 months, 4 months, they were labeled as neonatal hepatitis. Actually, the proportion of neonatal hepatitis is only 3%, as against 60%. So any child with neonatal cholestasis must be evaluated as a potential biliary atresia unless proved otherwise. So if I have to brief upon the causes of neonatal cholestasis, I would put them as biliary atresia, and biliary atresia. The rest all make a small fragment of it. Biliary atresia is something which we should never miss while looking at the neonatal cholestasis. And it is important to understand that whatever the cause of neonatal cholestasis is, every 2 of the 3 neonatal cholestasis children will be biliary atresia. What is important and why so much stress on biliary atresia? Because a timely surgery, which is Kasai portoenterostomy, will be life-saving. A child who we pick up as biliary atresia early can be offered surgery timely so that they grow and become adult, even though, and these are called successful CASI, even though they have a residual portal hypertension, which will gradually progress. Even then, transplanting a child who is 6 months, 8 months versus transplanting a child who is 10 years, 14 years, 5 years, 20 years is way different. The number of years that we give them with the native liver cannot be equated to saying that sooner or later the child would have required a liver transplant, so why not do it now? That doesn't stand true. What we do by timely picking up these children, apart from the timely CASI, is also that if we pick them up early, they will not have complications like intraventricular hemorrhage, intracellular bleeds because of the coagulopathy, and many of the otherwise normally developing children after developing the IC bleed become developmentally delayed. So we will also prevent that complications and also all the other complications of a decompensated liver disease in early infancy. This is why it is very important, even in this era where transplantation of even smallest of the babies can be done successfully, it does not mean that we should be pushing the children with biliary atresia to directly transplant. They must be timely diagnosed, offered CASI timely, and a good follow-up post-CASI, and then let them grow to an age where when the native liver survives. But what are the challenges in the neonatal cholestasis evaluation? The most important when we sit in the tertiary care centers is that the average time when the parents also come and tell even the primary healthcare worker is around 4 to 5 weeks when they first seek the advice, because the children are normally healthy looking and playing and developing well. And the average time that they present to a tertiary care center is actually 3.5 months. And the golden window for biliary atresia surgery is lost in majority of the cases. Then it necessitates an early transplant, which could have been potentially deferred by many, many years if we could early diagnose and do the timely surgery. So here the bottleneck is the delayed referral from the patient to the primary care and then to the tertiary level. To objectify that there is what we see when we sit at the tertiary care centers is that this is the data from ILBS. The children who came of biliary atresia, 60% were too late to be operated. And hence we lost the golden window period. And only 11% of those who came were operated less than 60 days. 60 days is the best time that they can be operated. They can be operated as early as 3 weeks as well. And 51% were operated between 60 to 90 days. The most important thing that the time of the surgery is the most important factor, which will decide the outcome of these children, and we lose them because of the delayed referral. Other important thing also is that in case a patient presents, the parents present with the child, even among the healthcare workers and the practicing doctors, the knowledge and practice for neonatal cholestasis is lacking. This one data I could get of Saudi Arabia, but I'm pretty sure it is the same in India as well. And it is our responsibility to spread the awareness. Half the people would not know that if a child comes with neonatal cholestasis, some of them will just say that the child is looking well and they can go back and come back again with the follow-up after a week. And this is the reason that the time is lost. Some of them directly go to pediatric surgeries, and many of them who are not biliary atresia also get operated. So the question is that whenever there is a child of neonatal cholestasis, the child must be referred to appropriate facilities, whichever is available in whichever city, in whichever state. The child must be referred early, and this must be expedited, or there must be a way to make this child identified as a high risk and moved up in the hierarchy very fast. So one important thought which I thought could improve this delayed referral is the introduction of the integrated neonatal cholestasis card in the mother and child protection card. Now, this card is a card which has been validated for the Indian population. The study was done in SGPGI Lucknow, and they validated this card in the Indian population using biliary atresia, non-biliary atresia, and the controls. And this is already published. So this is a stool card for our own country, and we should be using this card so that we will improve upon the referral system. So if we could introduce this card in the maternal and child care protection card, And also, if the ground root worker, like the ASHA worker, the Anganwadi worker, they are taught that whenever you go and ask about the child on the 1st, 3rd, 7th day or the 6th week, you also have to ask what is the stool color and look at the stool color if it is there and look at the urine color. It's not very difficult for anybody to learn these things, but what we will gain from this small exercise is a lot of early reference for these children. The thought came because a country like Taiwan has done it long back. They introduced their own stool card, which was validated in their population, and they have achieved a change. After using this card, they used to give these cards when the child was born, and 60% of their cases started getting operated at less than 60 days, and 87% of them got operated before 90 days of life, and hence their outcome and prognosis of biliary atresia improved. This is also another study from Taiwan where they said that after they used the stool card screening program, the 5-year survival of those children also improved. Before the stool card was introduced, 5-year survival of biliary atresia with the native liver was somewhere around 60%, possibly because they were operated late. Now, after the introduction of the stool card, there was around 95 to 90% survival with the native liver at 5 years. So this is one of the examples which I always show, that this child was operated at PGI Chandigarh because they were the resident of Uttarakhand, and this child is now 19 years of age with the native liver of biliary atresia. This might not happen with every child, but even if it happens with 20% of those biliary atresia who are treated early and have a good post-Kasai follow-up, this is worth giving these children. Whenever a child or biliary atresia is born, we must always feel that we are going to give this child this kind of a life because this is possible. The third disease that I would like to move is to Wilson's disease. It is the most common genetic liver disease. It is very much treatable, and more than 85% of children who are on chelation will live a normal life with the native liver. The prevalence in India is 1:30,000 live birth. Therefore, it also qualifies as a rare disease as per the WHO definition. If we look at the age-wise distribution of the various liver diseases, we will see that any child more than 1 year around, the Wilson's disease has started to become a cause. So the previous notion that Wilson's disease does not present before 3 years does not stand today. More so, with the sibling screening, we should be able to identify children much earlier than even the liver started to get chronic hepatitis, liver part cirrhosis. We should be able to catch these children early and give them a normal life and prevent even the onset of the disease. So if I look at the global prevalence of Wilson's from the next generation sequencing data, because a lot of genetic tests are being done and they do give very good information, especially for the asymptomatic sibling. It is justified, Wilson's disease is justified as a rare disease. And if I look at the burden of Wilson's disease, the familial screening is a very good way to find out these diseases. The hepatology, the hepatic form of Wilson's can be controlled very much, except in those 20 to 25% of children who will present as acute liver failure and fulminant Wilson's, where a majority of them would need transplant, but a minority of them who do not develop hepatic encephalopathy can still be salvaged with rapid chelation and supportive management. So when I look at this, I feel that a central registry for Wilson's disease is a must, because these children will require a lifelong follow-up, lifelong disease, and lifelong support, and all the siblings must be treated. Now, if we look at what the Wilson's disease burden we have in India, a study from a national Austrian registry, which is of 52 years, they have only 229 patients. India does not have a national data. So the only data which we have is from the tertiary care centers. And after a thorough review, I could find only 4 tertiary care centers which were giving data for Wilson's. And over a period of 6 years, we had in these 4 centers, we had total 338 cases which were reported during the study period with a mortality of 32%. And there was no data on the sibling screening, no data on the long-term follow-up. If we extrapolate it to how many Wilson's would be there in India needing the treatment. So if I consider medical colleges to be the tertiary care centers who will get Wilson's, there are 550 of them. That makes it around 6,600 new cases every year. And
the old cases will always remain. So this is a very large burden. Until unless we make central registries for them and the children know where to get the drug, a common area and a common follow-up, and nobody should miss their sibling screening, I am sure we can change the way Wilson's behaves in the country now. The lack of early diagnosis and long-term follow-up are the major cause that children with Wilson's are dying even though they were diagnosed 3 years back or 4 years back. Now, important modification in Wilson's disease, which is going to impact the way we pick up early Wilson's even before significant clinical features come, is the new scoring system. It has been accepted by the national and the international pediatric hepatology forums, and it is the modified Lipzig scoring system. It is important to get the undergraduates and the postgraduates get into a habit of knowing that, and this must become a part of the curriculum, that the previously thought of ceruloplasmin, 24-hour urinary copper, and KF ring are not the only things which are going to make a diagnosis. And this score must be utilized in each and every case to identify and pick up Wilson's early. The earlier we pick, the better we are going to get their outcome with chelation. Another important thing for Wilson's is that we should take measures to make sibling screening mandatory. Many a times, even though the practitioners tell the family, but they because just one child is sick, so they want to give all their energy to one child and let the other child roam around, or they're too scared that the other child would also be labeled as Wilson. In case we have some sessions, some counseling areas where the parents can be given time to understand what we talk about, and I'm pretty sure once the parents understand, no parent will run away from sibling screening, and we would be picking up children who will survive all their lives. This is the data from outside India, and they've showed that a 20-year survival and even a later survival in children who were non-cirrhotic of Wilson's disease, who were non-cirrhotic, had a very good, almost near life expectancy, as against children who were started on chelation with the cirrhotic liver. So our goal in India should be to pick up these children early. The rest will anyways come to us in the clinics as symptomatic, but we have to increase the number of the pre-symptomatic which reach us. And because of we all know it's an autosomal recessive trait, we understand that even if I diagnose one new Wilson's disease today, I can diagnose at least 1 to 2 of the pre-symptomatic sibling of that child and completely prevent the onset of disease by starting early chelation. And there is no better liver than your own liver. And we should push all the efforts from the government, from the non-government organizations to make sibling screening for Wilson's mandatory. The other important issue is that while going through the National Rare Disease Policy, which was adopted by the Government of India in 2021, Wilson's doesn't find a place, even though it is a rare disease as per the prevalence and as per the WHO definition. So in case we should put efforts to put Wilson's disease in the National Rare Disease Policy, because it is the commonest rare disease of children which we can take care of. And hence, there's one important thing about the policy is that they have group 1 disorders wherein which are amenable to one-time curative treatment, and there is an option of single-time financial aid from the government under the Rashtriya Arogya Nidhi for both below poverty line patients and as well as for patients who are eligible for the PMJ scheme. If we add Wilson's disease to this list at present has diseases like tyrosinemia, glycogen storage disease 1, 3, and 4, maple syrup urine disease, urea cycle disorders, and organic acidemias. In case we are able to, and we should work towards putting Wilson's disease in this list, and I'm sure so many of the children will be benefited by this, because there will be still 20% of those Wilsons who are acute fulminant Wilson who will require a transplant. At least they can get timely transplant and financial aid from the government. Lastly, I would like to talk about the liver transplantation in children. In India, there are only 10 pediatric liver transplant centers who are doing high volume pediatric liver transplants. The liver transplants are mainly of 2 types, the living and the cadaver donation. In India, especially for the children, the major program is live donor, living donor program. Also, from the adult side, also the living donation is much more than the disease donor. And India has these areas, all these centers, which are major pediatric liver transplant centers, and they are definitely accumulated among metros. So there's a huge lot of population for whom reaching to a liver transplant center itself a big thing. But the time that they spend in going from one doctor to the other and finally reaching the liver transplant program, half of them do not even reach here. And there are now increasing over the years, there are increasing centers who have disease donor activity also. And gradually, it is good that we have disease donors because for a child, from the adult liver also, a portion can be given to a child and the rest of the portion to be to the adult. So the split liver also makes more organs available to children. So what are the long-term considerations in pediatric liver transplant? The scenario has changed in the last 5 years. Long-term survival is now an expectation in pediatric transplant rather than an exception. This has resulted in shifting the focus on long-term allograft health, a life free of complication because of the immunosuppressions, and also self-reported well-being. There is an increasing recognition of importance of patient-reported outcome measures, and e-versions of the patient-reported outcome measures are being created to increase accessibility and also to understand the medium and long-term issues this child who's growing up now and the families face, especially when they become young adulthood and go into the society and looking for jobs and their family life. There are definite barriers to ideal long-term pediatric transplants. As the time has evolved, we have been able to come to tide over many of them. Listing has been expedited. There has been majority of the pediatric transplants, even smaller babies are now uncomplicated, having an uncomplicated intraoperative and perioperative periods. Children as small as 6 kgs are extubated before they are shifted to the ICUs after the transplant. And we have been able to recognize early graft dysfunction by strict follow-up, and also these children are now growing up. An important thing here is to optimize and sustain the health of these patients and the health of the graft. Hence, in line with building a digital infrastructure in the healthcare, it is important that since we are now producing a population of children who are post-transplant, every year now in India, around 150 to 200 children are being transplanted across India, and it is going to exponentially rise in the next few years. So we must be aware that now we have a population of children who always require a medical follow-up, and we should be ready that now they're going to come with issues with adolescent revolution and transition from the pediatric care to the adult care. And we should have things in place so that tomorrow these children who were transplanted 10 years back do not go out in the society and have issues with the self-esteem or the need to take medications all the time. And many of them has been seen in the Western countries that once they reach the adolescent, late teenage and the young adulthood, they stop taking medications and they go into rejection. And this is important that now it is high time that India should have transition clinics also to understand that now the child is growing and becoming an adult, being responsible for his medications and even the procurement of the financial help. So with these, we have started work on developing the e-versions of patient-reported outcome measures. There is now this is in the pipeline to be published. One important thing which I had believed is to have a formal pediatric liver transplant quality of life index. It was initially in English. Now it has been translated and validated in 11 languages across the world. And I'm happy to say that it has been validated and translated into Hindi. And very soon we can use these kind of portals and quality of life care to give these children also a cover for medical care while allowing them to go into normal life. We cannot keep the post-transplant children as patients all the time. They must go and enjoy their life, but we must keep a check on what is their quality of life by enrolling them into central registries so that we know which patient has is stop taking medications which patients is going through difficult times. And what are they doing once they grow up? What kind of jobs are they going to go? These children are going to go, and now when the parents come to us, they start asking, will he be able to go to work when he grows up? Will he be able to earn for himself? So these are questions which now will come as routine to us, rather than, would transplant be successful? Transplant is going to be successful because the surgical expertise, the intraoperative and perioperative care has been improved tremendously. And so the key messages I would like to share would be that we should always try and save the native liver. It is much easier to save the liver in children as compared to adult. Not every cirrhotic will need a transplant. Many can be salvaged without transplant. Early referral is the key. And liver transplantation have good outcomes. It can give a new lease of life to a child who is likely not salvageable otherwise, despite the best medical care. We already have many of the government good schemes which are in place. Only if we improve the quality, if we put more focus on the quality improvement within the realms of these policies, we can actually make and create a change, and for good, to a lot of these children who require the pediatric liver and hepatology and gastroenterology services. But we must have to have a robust referral system in place. We have to create awareness by multiple ways, and it has to be continuous so that people would start talking about liver transplant even when somebody comes to a secondary care, to a district hospital, to a community health care. Many times, by the time patient reaches a private dedicated liver transplant center, they have not even heard of transplant. So now we should understand that transplant should be also a way that it has the undergraduates and the postgraduate know what transplant is. They should not feel that this is something which is too far-fetched. It is a reality. We are going to have post-transplant children in future, and we must give it timely and offer it timely. So with this, this is a 20-month-old child who was the first pediatric transplant for the country in the 1998. Now he's 24 years old and is training to be a surgeon. He was a biliary atresia. So I would just end it.
We will invite the participants to please key in their questions. I think this has been a very informative session. And any question and answers can go directly into chat box with your name or into the Q&A for the chairpersons to initiate a discussion after we are through. So Rahul, could you get the presentation?
Yeah, I got the presentation. I'll just share in a moment.
Yeah, so just hold on for a moment. Till that time, I think the participants can think about the questions they need to ask or any observations with their names into the chat box. We'll have Dr. Aarti and the very eminent chairpersons respond. And I'd also like to have the perspective from the chairpersons at the end of this session regarding their own experiences in on the various aspects raised by Dr. Aarti, as well as by Dr. Vinendra related to the setting up of the hepatology program at ILBS, some perspectives and how QI can help, sir. I think we would be very eager to hear about that. So I think by the time Dr. Rahul plays it, I think I will call upon Dr. Sanjeev for his inputs.
Yeah, thank you, Dr. Datta. Amazing presentation, Dr. Aarti. It's been quite some time that I've never heard such a comprehensive outlook to the pediatric gastro issues, where you have covered whatever was required from the clinical perspective, and you have very aptly covered what is required as a solution and also a public health issue. So you have merged it so cleverly with the existing problem, and you're given a public health solution. So congratulations, and I really enjoyed listening to you.
Thank you, sir. Thank you.
A very quick question from my side is that you mentioned about this neonatal rare disease portal and their policy. So is there anything which for the Wilson's disease, so if it is treatable and if it is inclusive, is there anything different with the government? It's only inclusion of this in the rare disease portal. Will it solve because it is 100% treatable and 100% preventable?
So the only thing which comes as a difficult part in Wilson's, which I also have faced, is that the acute fulminant Wilson's is the only one which is going to need a very high financial help, and no family has been able to put across 16 to 20 lakh rupees in 24 hours. The rest of the diseases, the drug for Wilson's is from Panacea, which is very cheap. The Panacea has been helping poor people, and we also have access to the drugs which we can give to them lifelong for free. There are ways and there are CSR activities which are ongoing. So what I feel most important is not the cost of the drug for DPEN, which is important, but it is important to keep a registry that who all are Wilson's. There will be a time where parents are from far-flung areas where they might feel that my child is okay and they lose it, and also not do the sibling screening. So the first solution is, in case there has been cases where if I sit with the patient for 1 hour and tell the family that this is going to the outcome, come what may, wherever they are in the country, they are never going to stop the drug. They are never going to shy away from the sibling screening. Only thing is that they are not, nobody gives them this information. And definitely in busy hospitals, you cannot be giving 1 hour to one patient. So what I feel is that once somebody is diagnosed as Wilson's or suspected at Wilson's, they must be moved to an area, because the outcome from that registry or from that group of team people is much more than the investment. It's easy. The Wilson's disease children are going to come once in 3 months, once in 6 months. It's easy to follow them up. They should be able to, there are already ways where we have worked, where we have been collaborating with Panacea, which is the only company which makes D-penicillamine, to make platforms offline and online, which will be shared, which will have their investigations, previous investigations, all data or on an app. And these things are going to get them connected. They don't have to run from one village to the other. They know my phone is here, I can get connected to the people. So that central registry for Wilson's is a very, very big step. The drug availability and the costing is not a big issue for Wilson's, because we get so much of funding from so many areas. Even now, all the transplants in the last 6 months that we have done, we have been able to raise money. There are funds which are being raised, easy funds which are coming for the transplant services. But we don't want everybody to go for transplant. We want children who can improve with transplant. Our effort should be to them also. And that is what is going to change. From them also, transplants are going to come. The country is going to have transplant, have good data. But those children whose liver can be saved, all the efforts should be to them.
Right. Very pertinent. Dr. Pamecha, very good to have you as the chairperson. Can I ask you to take over? And you have immense experience, and congratulations for establishing such a fantastic program at ILBS. So over to you.
Thanks, Dr. Singh, and thanks, Professor Datta, for having me here. Aarti done an excellent job, actually. Very nice talk. The way you have covered from hepatitis A to then coming down to congenital biliary atresia and then metabolic liver disease. So that's a fantastic thing. And also the way you have put up the perspective that how to make an early diagnosis, and then how this basically the treatments which are available now, which can actually change the quality of life of these kids by just applying simple measures. That was very nice, actually. So just coming to the the transplant end of the side. So in India currently around 2,500 liver transplants are being performed nationwide, and the need is more than around 40 to 50,000 liver transplants. And if we come down to pediatric breakup, so we are expected to do around 5 to 10% of that activity should be pediatric liver transplant. So the need is around somewhere around 2,000 to 3,000, maybe more actually, pediatric liver transplant need to be performed in the country currently. And what we're doing is maybe around 200 pediatric liver transplants are happening in the country nationwide. So there is a huge gap between what is happening and what need to be done. And I think the major hurdles in terms of this gap need to be filled up is, one is accessibility to the care and the cost. These are two areas where everybody need to work around how actually to make this particular treatment available to the patient. And that's where I think public-private partnerships come into play, where actually we can actually support various hospitals, institutes in order to develop pediatric transplant program. And honestly speaking, actually to me, pediatric transplant program, establishing a pediatric transplant program is much easier than an adult program, because most of this pediatric transplants are going to happen through a live donor liver transplant program. And it's very good operation in terms of a parent donating to their children, rather than in an adult where there are lots of things in terms of finding an appropriate donor for a particular recipient. But pediatrics is a very good operation in a way in terms of live donor liver transplantation. It's a fantastic operation to be done. And most good hospitals have got now good pediatric ICU cares available. And that's what is needed in terms of looking after them after the operation. And the surgical expertise actually have developed so nicely now that we are able to perform in very low weight children's. And also the age is no more a barrier, that there is, previously it was like you can't do below 6 months or 8 months or at 12 months, but those barriers have been crossed very nicely and the results are very good. And the long-term impact has been very good in all the kids. So that's the just brief onto the pediatric in terms of coming to small kids. Then the other one, acute liver failure. I think we are one of the centers who have done most number of acute liver failure transplant, and we still get lots of kids actually coming with viral hepatitis or unknown etiology with acute liver failure. And an early detection actually and a timely referral can make a very good difference in the life of these kids. And the post-transplant survival now range 80-90% actually in these kids as well. So if they come timely, and then there is a good opportunity, many of them actually will just improve without transplant. You don't really need to push everybody for a transplant. We've been very careful in selecting out. We don't do without criteria, without satisfying criteria and all. So if they're referred properly, and then a good ICU care can make a big difference. So that's a very important point which Aarti has already emphasized. I'm just again saying. And biliary atresia, again, we've crossed the age and weight bar. There are good long-term results, and the techniques have improved dramatically. So it's a matter of how to get this care available to the general public of the country, common man actually, which is what is the difference. And I think that's where Government of India is actually trying as well to build up packages which can become affordable. Ayushman Bharat has come up, and they already sorted out the kidney package. They want to sort out the liver package as well. And I think somewhere, even if half of it is shared by somebody and half is afforded by the patient, then many more patients will actually be able to afford this. Honestly, if you ask me, pediatric transplant cost to cost is around 5 to 6 lakhs. Okay. And rest actually, if it is managed out, then in a public sector hospital, it will cost 5 to 6 lakhs actually. And if this can be managed out, obviously the cost in the private hospital will be very different from public sector hospitals. And that's where it is. So the way I see is, cut to cut cost, this, if, part coming from patient, part coming from NGOs, then we can actually make a big difference in care of these kids. So that's my brief on all this. I don't know what to ask Aarti, because she has already covered most of the things. Thank you very much, Aarti.
Thank you, sir. Thank you.
I just wanted to make
Dr.
one
Pamecha, Dr. Sandeep, we can see if there are some questions. I think two participants have raised their hands, sir.
Right. So there is one question which was asked: is immunization contraindicated for newborn with liver disease?
No, it is not absolutely contraindicated. One important thing to understand is that all the immunization will be on time. But in case a child is likely to go into transplant at around 8-9 months of age, there are catch-up accelerated vaccinations that all the live vaccines are put at an earlier age before the transplant happens. So for me, if a child is getting transplanted at 7 months of age, his MMR is also given before, and all the other vaccinations, live vaccinations, are done before. And after transplant, no live vaccine, and 6 months after transplant, killed vaccines can be given. But for liver disease, there is no contraindication. Only thing is important that in case the child has coagulopathy or the child had cholestatic jaundice, we always give vitamin K injection 10 mg either orally or IV a day or two prior to a immunization in case of decompensated liver. If a child is on supportive management, you don't even need to get specifically before the vaccine, but the child should be on supportive care, including a vitamin K medicine as a part of supportive care.
Right. So, Dr. Aarti, I just wanted to mention one point. Since I've been largely in Kerala, the IMR, I think, went through a single digit. And MMR also came down to 30. What largely was done is this, the associations of Obs and Gynae and Indian Academy of Pediatrics came together and they started auditing. So if IMR is because of the infant mortality is because of septicemia, congenital heart disease and birth asphyxia, they took care of all these things. So is there something which could be established within the group of pediatric and pediatric gastroenterologists where they come together and you audit some of these findings randomly and create an awareness so that there is a better referral system, which you are already mentioning? So is there something, I know that the child
I think there's some network issue at Dr. Sanjeev's place, but Dr. Aarti,
because can we follow some of that?
Definitely, sir. This is something which I dream of, that there should be a team of people who, there needs to be a team formed who will look after this, because it will not take more than a day or two for us, if we are a team of 10-15 people, to spread out and, get this thing as a workshop to maybe a medical college, to be a big hospital, healthcare institution. It wouldn't take. And I have experience of when I go to my outreach OPDs, I have myself wished and volunteered to go to medical colleges. So those residents, the pediatric resident in the medical colleges are the most enthusiastic people that we can interact with. If you tell them one finding, they are going to, always get back to you with, the follow-up of the patient. So we should get these things and more emphasis on pediatric gastroenterology and hepatology at the postgraduate level. I remember that when I passed my MD pediatrics, I couldn't diagnose a biliary atresia, though it was there in the book, possibly because it came as a short case and we were more bothered about the CNS and the CVS. But these are also the cases which should become active part and important part of the curriculum of the postgraduate. It is not difficult to pick there. So I think a team of people, once it is formed, and I'm sure one day it will be formed, and I have people that they will form it. So they have to spread out and improve. The quality will only improve then.
Perfect. My last question, very quick answer, Dr. Aarti, is if the parents are affordable and there is an acute liver failure neonatal, if it is a biliary atresia and so can you still would like to recommend Kasai, or it could be a live donor transplantation?
If the time window is there, the child is not more than 90 days of age, and we do not have any other contraindications like ascites in the child at that time, we would still go for a Kasai, always a Kasai followed by a transplant. The debate over Kasai making the transplant difficult has not stood the test of time, and there is no issues with the transplant if done after Kasai, but definitely it's not only the age. There are different types of biliary atresia, different severity of biliary atresia, which will let us decide whether we should be operating this child or not at a specific age. By a rough golden standard, less than 60 days, they are most likely. By 60 to 90, err on the side of doing a Kasai if no contraindications. If more than 90, then we'll have to weigh our risk and benefit. We don't want the child to go into a post-Kasai decompensation of the liver and worsening. So the decision lies in that. But yes, first Kasai, then transplant.
Thank you, Dr. Aarti. Your passion is very contagious, and I really enjoyed your talk. Thank you so much. Over to you, Dr. Datta, and congratulations for creating such a fantastic forum.
Thank you so much, Dr. Sanjeev. I think there's one last question, I think, for want of time, though this is a very interesting session and lots of knowledge for us also. So, Dr. Aarti, the question comes from Geeta Rani. She is a ANM, and we are very happy to have people from the primary healthcare also participating in the communities of practice. So she says, as we are initiating complementary feeding at 6 months, along with breastfeeding, including oil and green and red vegetables and fruit, is oil contraindicated or can it be given? She's not specified whether she's asking this question pertaining to a child with a suspected liver disorder or some gastroenterology related issue or a normal child. So I think you need to be very specific related to a hepatic disorder if we are suspecting. There's
no need to stop oil. Rather, the coconut oil, which is rich in medium chain triglycerides, are given to children with liver diseases as a supplement because it gets directly absorbed without the need of bile salts, and they should be given all kinds of oil, and half of the, if possible, half of their complementary food should be cooked in edible coconut oil. But they should take 50% as normal oil to prevent the deficiency of essential fatty acids. So it is, we welcome, it should be 50% of cooked and coconut oil to be added in the diet.
So I think one last question from Dr. Aritra Ray, who's a neonatology DM student at Lady Hardinge in my unit. Dr. Aritra, what do you like to ask from Dr. Aarti? Please unmute yourself and ask.
Actually, my question is, sir, what is the outcome of post-transplantation in GALT patients? Because most of the...
Can you please repeat it? Post-transplant in?
GALT patient, gestational autoimmune liver disease, ma'am.
Gestational autoimmune liver disease?
Yeah.
Their outcome is no different from others, but there are not, if you see, there are not many gestational autoimmune alloimmune liver disease which reach to the transplant. They are many of the time extremely sick in the newborn period itself, that they do not reach the transplant, but once they reach the transplant, they are not much, the outcome is not worse. There is no reason for the transplant to have worse outcome, except the sickness of the child at the time of transplant.
Is it necessary to wait for 8 to 9 months before transplantation?
No.
Because, okay. Can we actually do it earlier?
Yes. The condition of the child will determine when the transplant can be done.
Age is not a bar. You know, this normal thinking about avoiding transplant until 6 months, 8 months, age is never a bar actually. So we have done 4.5 months as well, and age was never a bar actually. It was previously, it was thought maybe the anesthesia issues and surgical technique wise, but currently if you look at the things, age is not a bar for transplant. So we do get neonatal acute liver failures as well, and we have transplanted them as well. And so what determines, even in Kasai, as Aarti was saying, it is decompensation which makes the difference. Once a child is decompensated, then to do a Kasai is not right. You should offer them primary liver transplant, because the results of primary liver transplants are very good actually in most children. And just to think about the decompensate now, this is the end of the journey. It's not like that. So even children with decompensated liver disease in biliary atresia, if they are timely transplanted, they have a good outcome.
So thank you so much, Dr. Pamecha. Dr. Aarti, I think it has been an enlightening presentation for all of us, including many of our DM students and our primary healthcare workers. So you can see the spectrum. The felt need is so much that we have questions even from our ANMs who've been attending the platform, and that is how we have equity in healthcare by the means of the communities of practice. And that is a great part. We have a DM student asking a question, we have a consultant, we have a frontline healthcare worker. So just to summarize, I think from the quality improvement perspective, since this is a point of care quality improvement communities of practice, the issues which you and the most eminent panel and the chairpersons have raised is related to what I got as a basic neonatologist, is that there needs to be a structured program for creating awareness. That is one, awareness not only in the healthcare workers, but most important, awareness in the frontline workers as well as the community. Now, we should work using all the implementation sciences and the quality improvement approaches to create these awareness generating activities. And like we know, the publications have an impact size of only 1.5%. You make a guideline document. I've been speaking at IAP recently multiple times. The Lancet systematic review says only 1.5%. Trainings only 10% impact size. So quality improvement plus clinical skill building 56% impact size, and that is something which we need to club in. And I think the national group of hepatologists, gastroenterologists need to get the point of care quality improvement along with their clinical skill building session into reducing the no-do gap. That is something which is very, very important. You raise another very important point, that the pre-service people need to be targeted. That is the residents. I think nursing colleges, our A&M training centers, etc., also would serve as a very fertile ground where we should target simple things like you said, the color of the stool or the development of jaundice or the child not feeding well. These are something which need to go into the Mother and Child Health Protection Card. So that is something which is very, very important. Referral linkages. I think Pamitra sir mentioned that if the child reaches a government hospital, the cost is only 1/4. And sir, of course, 20 lakh rupees, sir, I think even none of the government officers can afford to bring out of their pocket. So a common person who's living, they would rather say that this child can go, they can have 2 more, you know. It is very bad to say like that, but that is the way most of them have to satisfy themselves that to iska kuch ho nahi sakta, let's leave him. So I think with the health insurance schemes, the Ayushman Bharat and the Prime Minister's support, I think we need to create awareness. JSSK is another program, Janani Shishu Suraksha Karyakram and Janani Shishu Suraksha Yojana. I think in our hospital and also in Delhi, less than 10% utilization rates were there one time. And most of the funds the hospitals are not taking, they are not utilizing. So I think as healthcare workers, sir, there is a greater need for us to raise awareness regarding the utilization of these facilities which Government of India is providing to the masses. And the last and the most important part is that more such sessions regarding experience sharing and the organizations. That is, I'm sure, like I represent the National Neonatology Forum and NQCN and IAP. I think the gastroenterology and the hepatology organizations, I feel you must be having a community involvement or a community awareness program or a referral linkage strengthening program. So one last word from Dr. Pamecha sir regarding how we could strengthen all of this community involvement in these programs, and how many would know that if they go to ILPS will just cost 5 lakh rupees. And even we were not aware that age is no bar. We used to feel that 6 mahine ka to ho jaye bacha and then we will send. You know, so sir, how do we create that awareness? Any structured program which you feel, and how ILBS can contribute to it, and hepatologists like Dr. Aarti, Dr. Sanjeev?
So this is the most important point. Basically, how we create awareness. Obviously, as Aarti emphasized, some of this goes into the curriculum. All these points which have been discussed, they should go into the curriculum of MD medicine and the pediatric medicine as well, to emphasize that what happens is I keep saying always that what they do in the textbook is when they're writing the management plan, they'll put liver transplantation in the last. Okay, as a last resort, this is the last resort, end of. So before you're going there, just visit liver transplant. So that's not the age of medicine we have now. And this should be emphasized because, I keep saying here as well, that this should be emphasized that it's a timely transplant which makes a difference. So timely referral to the patient, timely transplant can make a difference. Now, the biggest hurdle we face is the cost. And I know there are lots of NGOs who are happy to help. There are lots of CSR schemes which are available, Airport Authority, Coal Authority. There are lots of people actually who are coming forward and helping. And part funding can always be arranged. And, if patient can't afford the whole of it, they can get the part of it and all this. And once the Ayushman Bharat package will come, then the whole thing, this will change the game plan in terms of in terms of affording this operation. Post-transplant medications, they are now available everywhere actually. All these tacrolimus and everything is available on the stores. The generic stores are available, and they are as good as we've been using generic medicine here in ILBIS, honestly. And even our ICU is on generic antibiotics. So it's not like we and we're doing well in terms of the outcomes and all. So I think those are the things. This are the messages just need to go out. Like you have organized this. This is very nice. I think today lots of information has come out, and I think this will spread out. And that's how we have to just build up things to reach the numbers we want to have it to get the care available to more and more.
Thank you so much for that explanation. I think that is the need of the hour, and the need of the hour is to have more such interactive sessions with people from different disciplines. I think few people were mentioning to us that why we are diversifying from the maternal and neonatal health, because the theme of this communities of practice is only, neonatal health and maternal health. But we felt that we have to get the spectrum, sir. We have to have a continuous continuum of care, because the neonatology pediatric colleagues even face the hepatobiliary disorders. And I think so is the case with the antenatal mothers who have to face, the postnatal mothers who have to face the brunt of having a child with a biliary cirrhosis or losing a child to one because of want of care or because of lack of affordability. And we felt that these are very related. And unless and until there is a synergy and there is an interactive platform which can provide the sharing of ideas, I think we would all be in the dark and continue to be in dark for decades to come. So thank you so much, all of you, for attending this Communities of Practice session. We look forward to hosting many more such sessions, and would also invite you to also attend some pediatric neonatology, obstetrics and gynecology quality of communities of practice sessions in future, and share your ideas and widen the perspectives, and also invite your students to be a part of this very vibrant community. Thank you, Dr. Aarti, Dr. Sanjeev, Dr. Pamecha, my colleagues from NQCN Governing Board, all the members of the communities of practice, and we look forward to an exciting session next month. Thank you so much. So, yes, sir. Thank you so much, sir. Thank you, and good night, and stay safe, everyone.
Thank you, sir.
Thank you.